Well, thank you. Unfortunately, this talk will have some overlaps with the previous talk given by Dr. Babev. Anyhow, oops, that's the end. No, oops, wrong direction. Okay. Rob, it's probably not the first slide. Okay. Okay, let's do it like this. Okay, these are my potential disclosures. Well, we have heard about that a variety of atherectomy devices has been introduced into the market during the last 2 decades. Important is to realize the design differences. We have directional atherectomy devices like the Hawk technology, but also the Phoenix can be deflected and therefore be used as a directional atherectomy device. Then we have rotational aspiration front-cutting atherectomy devices like Jetstream. Bicross is a new kid on the block in Europe, and then we have these sending devices, orbital atherectomy, and also the rotablator. What we learned from the IMPACT Global study is that overall the performance of drug-coated balloons in femoral popliteal lesions is pretty good, I would say. This is 5-year freedom from reintervention. It's in the range of 70%. However, it's worth to realize that in lesions included into this study with a mean lesion length of 12 centimeters, stent rate was about 25%, and if lesion length was longer than 20 centimeters, it did exceed even 50%. And the same has been found in the sports study, which was a randomized study comparing DCB versus bare nitinol stent and DES in long lesions. You can see over here, mean lesion length about 22 centimeters, and moderate to severe calcium being present in about 3/4 of all the lesions included. Bailout stent rate was 58% in the DCB cohort. So stenting, bailout stenting is an important aspect of using a drug-coated balloon in long femoral popliteal lesions, and despite that, the Eluvia drug-eluting stent at 1 year did perform the best in terms of the primary endpoint, which was angiographic stenosis. A recent study published from our colleagues from Japan did identify a couple of risk factors resulting in restenosis following drug-coated balloon angioplasty, and modifiable risk factors have been identified as being residual stenosis, severe calcification, and the presence of CTO. And almost a similar outcome came from a pooled analysis of data where the IMPACT Admiral drug-coated balloon was used. Again, residual stenosis more than 30%, post-procedure, acute after the intervention was the major driver of binary restenosis. So we have seen already the data from the definitive AR study. What we can definitely improve is the acute outcome in terms of reducing restenosis or residual stenosis to less than 30%. This has been shown by this study. It was almost 90% in the combination of atherectomy plus DCB, whereas a residual stenosis of less than 30% was only found in 2/3 of the lesions where DCB only was performed. This is a typical case coming from the definitive AR study. You can see over here severe calcification of the entire femoral popliteal artery. Here it's really concentric calcification, total occlusion of the distal SFA, reconstitution here at the upper level of the patella, so meaning the lesion did also include the popliteal segment, that's the outflow. And this is the result after directional atherectomy followed by DCB angioplasty. And you can see over here, this is persistent after 1 year. That's the angiographic follow-up in this particular patient. So if we remove the plaque, we are more likely to achieve a result which is satisfying, defined as a less than 30% residual stenosis. Very similar outcome was found in the reality study. Important is what we want to avoid is stenting, and you have seen in the sports trial with a mean lesion length of 22 centimeters, there was 58% of bailout stent rate, and this was reduced to 8.8% within the reality study with a mean lesion length of almost 18 centimeters. So preparing the lesion with atherectomy does improve the acute outcome. Whether it translates in longer-term benefits, that has to be determined. The problem is, if you are dealing with very long lesions, 20 or 30 centimeter long lesions, atherectomy is a painful procedure. It takes time. You have to remove the system to clean it if you are using directional atherectomy. So we developed a kind of adaptation of bailout stenting or spot stenting, which is we define as spot atherectomy. And what is it? It's basically pre-dilatation with an appropriately sized plain balloon or specialty balloon of the lesion for 3 minutes. If we see an optimal outcome after this pre-dilatation, we go directly to DCB angioplasty, and that's then the final outcome. If the outcome is suboptimal, if we see residual stenosis dissection, we go to focal directional atherectomy. So the idea is not to approach the entire lesion length, but the area which is not responsive to balloon angioplasty. And if this looks good, we are going to DCB. This is a case example. You can see here a patient after thromb end atherectomy of the common femoral artery of the left side, total occlusion beginning at the origin of the SFA reconstitution in the distal SFA segment. So here it was, even with a re-entry system, with a needle system, impossible to directly enter into the intraluminal segment, so the wire went subintimal initially. Retrograde access was used. You can see here it's a kind of card technique. It's a rendezvous technique using retrograde and antegrade access. This is pre-dilatation with a regular balloon, and what you can see over here is basically 3 lesions, focal lesions, not responsive to directional atherectomy. The third one is here in the distal segment, and after placing a spider filter, I did approach these 3 focal lesions with directional atherectomy, followed by DCB and angioplasty. With this outcome, I was happy with this. Even it was clear that there was some residual membrane here in the distal segment. The problem was this residual stenosis at the origin. You can see it's a floating thrombus, so this could not be removed with directional atherectomy, so a 2 centimeter long stent was implanted. The other device, which is effective and should be part of any atherectomy strategy in femoral-popliteal arteries, is the jet stream system. By definition, it should focus on calcified plaque, so elastic tissue shouldn't be damaged significantly, and the idea of differential cutting is that mainly calcified atheroma will be removed by this technology. We did the initial evaluation of this particular device in Europe, including 172 patients. And what you can see over here, this is the incidence of reintervention at 1 year, 27%. That's not an optimal outcome, but this was before the DCB area in SFA disease. You can see here the data had been published in 2009, so it's a longer time ago. So this is outcome of atherectomy plus plain balloon angioplasty, just a case example where I see a good indication for front cutting. atherectomy devices. This is the result after atherectomy followed by plain balloon angioplasty, and this was the angiographic outcome 3 years later. We could already, within this initial experience, show that this kind of aspiration, rotational atherectomy does result in a bigger luminal gain as expected based on the outer diameter of the device itself. So by some oscillation of the cutter, the size of luminal gain is bigger than what you can calculate based on the burr size, and this has been shown also already in this time based on IVUS. So what is my treatment algorithm? If we are dealing with none or moderate degree of calcification, directional atherectomy in focal lesions is my preference, followed by DCB. DS only if the lesion is not responsive to atherectomy. If we are dealing with long lesions, I prefer rotational aspiration atherectomy over directional atherectomy, followed by DCB. And if we are dealing with severe calcified lesions, focal lesions treated with directional atherectomy plus DCB. And if we are dealing with long lesions, again, it's rotational atherectomy in case if you could cross the lesion in the true lumen, otherwise lithoplasty may play a role. Thank you very much.